Hi, my name is Rebecca Marsh. I am an imaging medical physicist at the University of Colorado School of Medicine just outside of Denver. I included this picture of me so you have some idea who's speaking to you over the internet. It shows what I'm often doing when I'm not talking about patient shielding. So in this presentation, I'm going to be talking about patient shielding in 2020. I have no conflicts of interest to report. Most of you are probably somewhat familiar with the AAPM position statement that came out about a year ago, in April of 2019, that discusses the use of patient gonadal and fetal shielding in diagnostic imaging. In a nutshell, it says that science does not support shielding patients by default, including for pregnant and pediatric patients, and that this applies to several X-ray-based imaging modalities, including radiography, CT, fluoroscopy, and mammography. It also recognizes psychological effects, specifically that for some individual patients, there may be specific circumstances where the best care for that patient is to provide shielding for them. One example is if you have a patient who refuses a medically necessary imaging exam unless they are shielded, and the information from that exam is critical to the acute care of that patient. However, this should be patient-specific and is not a reason to continue to shield all patients. Shortly after the AAPM put out their position statement, it was endorsed by several other professional organizations, including the American College of Radiology, COMP, Image Wisely and Image Gently, Health Physics Society, RSNA, the Canadian Association of Radiologists, and the Australasian College of Physical Scientists and Engineers in Medicine, which represents scientists and engineers in Australia and New Zealand. Last month, a group of British professional organizations released a white paper providing guidance on using shielding on patients for diagnostic radiology applications. The report was a collaborative effort among British radiologists, radiographer, physicists, engineering, and public health specialists. This document reiterates what is included in the AAPM position statement, but expands upon the underlying science. It also addresses areas not discussed in the AAPM position statement, such as thyroid shielding for dental X-ray. But the conclusions in this white paper are the same as those of the AAPM position statement, that science no longer supports the use of patient shielding as a routine practice in medical imaging. So over the next 45 minutes or so, I'm going to try to answer the following questions. Why was patient shielding introduced? And does shielding patients still make sense? In this discussion, we'll talk about the benefits and the associated risks with patient shielding, and briefly touch on current and continuing work. Before we discuss patient shielding, it's important to remind ourselves that the main goal of radiology is to produce images that help guide clinical care. Safety is important, but if we fail to produce quality images, we've missed the goal entirely. So let's take a look at the timeline of patient shielding. If we look at where we've been and where we are now, it can help elucidate some of the current conversations about patient shielding. The first significant date is 1953. This is when we start seeing more articles about shielding patients' gonads. People had talked about gonadal shielding previously, but in the 1950s, there were several papers that advocated the use of gonadal shielding. This is also when gonadal shielding really started to come into mainstream clinical use. The next significant date in the evolution of patient shielding is 1976. This is when the Food and Drug Administration added wording to the Code of Federal Regulations suggesting that gonadal shielding be used during all X-ray exams performed on people with reproductive potential. In other words, anyone who's of childbearing age or younger. The only reason given for this suggestion was to decrease the risk of harm to the human gene pool. People were concerned about potential hereditary effects from radiation. Even now, 44 years later, the wording in the Code of Federal Regulations remains exactly the same as it did in 1976. It's important to note here that the suggestion in the FDA Code of Federal Regulations to shield patients' gonads was not actually a regulation. It was, and still is, a suggestion, but not a regulation. And then we have 2019. As I mentioned before, this is when the AAPM Professional Policy 32A came out, recommending the discontinuation of routine patient shielding. It's interesting to consider how much has changed since the early 1950s, when patient shielding came into mainstream clinical use. One way to recognize the degree to which things have changed over the past several decades is to look at the evolution of computers during this time. In 1953, computers took up an entire room. 1976 was the same year that Steve Wozniak built the first Apple computer. By 2019, aside from catching some nice fish, I was able to fit substantial computing power on my wrist in the middle of a remote lake in Canada. So let's take a closer look at what was going on in the world of radiology and radiation research during this same time frame. So let's go back to 1953. War of the Worlds and Stalag 17 were playing in the theaters. The polio vaccine had just been developed, and over a decade before Elvis made the song famous, Big Mama Thornton was belting out Hound Dog over the radio. Concerns about radiation exposure in 1953 were much the same as they are today. People were concerned about hereditary effects in fertility, fetal harm, and increased cancer risk. So in 1953, what did we actually know about some of these things? Most of the concerns about hereditary effects stemmed from experiments performed with fruit flies in the 20s and 30s. Experiments had demonstrated that exposing fruit flies to large amounts of radiation induced genetic changes that showed up in subsequent generations of fruit flies. In that same decade, experiments showed similar results with mice. Similarly, information about radiation effects on fertility came from experiments performed on rabbits and other small mammals in the beginning of the 20th century. So by the 1950s, it was pretty well known that exposure to large amounts of radiation can cause temporary or permanent infertility. This slide shows some examples of gonadal shielding that was being used in the 1950s. The image on the left shows a capsule-type shield, and the image on the right shows a shadow shield, where the lead can be moved up and down along the stand so it is positioned above the patient's gonads, between the patient and the X-ray tube. In the late 1950s, there was a paper published by a radiologist, Paul Hodges, that discussed the current state of knowledge about hereditary effects from radiation exposure. He stated in his paper that, quote, "Without exception, all estimates of the existence, nature, and magnitude of radiation-induced genetic changes are based on inferences from high-level experiments on animals." He then goes on to comment that because we don't know definitively whether there are hereditary effects in humans, that, quote, "It is obvious that we should do everything in our power to reduce the amount of radiation received by the gonads." This speaks to what the thinking was at the time and why there was a push towards patient gonadal shielding. Work done in the early 20th century on the effects of radiation on a fetus focused on fetal death. A little bit later on, experiments on rabbits and rats reported radiation-induced malformations, and work with mice and rats showed that fetal radiosensitivity is different during different stages of gestation. The doses used in these experiments were on the order of 3 gray or 3,000 milligray. Case studies reported radiation effects on the human fetus that included microcephaly, mental deficiency, skull malformations, blindness, and deformities of arms, feet, and genitals. A paper in 1952 noted that, quote, "Most radiologists aware of possible danger to the fetus will, whenever possible, avoid irradiation of pregnant women," end quote. Interestingly, the authors specifically state that while one may think that diagnostic radiation wouldn't pose a risk because it uses relatively low levels of radiation compared to that used in animal studies, they cite results from an animal study that showed that radiation effects decreased in magnitude with decreased dose, but were still present at doses of 250 milligray. This was within the range of the dose used during a minute of fluoroscopy. During a study of 63 fluoroscopic machines that were in use in New Jersey in the 1950s, about 20% of them emitted more than 300 milligray per minute, with one giving as much as 1,200 milligray per minute. The authors of this paper concluded by saying that, quote, "Whenever possible in non-pelvic irradiation, the conceptus should be shielded." In the paper I mentioned earlier, Dr. Hodges discussed radiation effects on a fetus. He specifically mentions an article that was published in Science where the authors discussed that very little was known about radiation effects on a human fetus. They stated that, quote, "It is not possible at the present time to estimate with any assurance the effect upon biometrical characteristics of any given level of irradiation on human populations." So in essence, they were saying that a lot was unknown, and really you couldn't say with any certainty what fetal effects from radiation exposure were. Quite interestingly, in his paper, Dr. Hodges then goes on to mention a Times Magazine article that reports on the same article in Science, stating that it, quote, reported evidence that a single modern fluoroscopic exam of a woman's pelvis will shorten her child's life by 2 weeks. End quote. Dr. Hodges notes that the Times writer had completely misrepresented the original Science article and warned that it was strong meat that will be devoured and long remembered by the uninitiated. Most of us has probably encountered something similar, with media misrepresenting radiation risk to the public. But it's interesting that as far back as 1959, there was the same misrepresentation of facts. This likely increased the perceived necessity to use gonadal and fetal shielding in medical imaging. By the 1950s, the causative relationship between radiation exposure and cancer was well known. Between 1911 and 1914, there were 198 reported cases of radiation-induced malignancy and 54 associated deaths. By 1934, more than 200 radiologists had died from radiation-induced malignancies. This included Clarence Dolly, who had worked as Thomas Edison's assistant in developing the fluoroscope. Dolly's death was so jarring to Edison that he completely stopped all X-ray research, stating that he was afraid of them. In 1945, the wartime use of an atomic bomb started the first and, to this day, largest-scale study of radiation effects in humans. By 1953, data were limited by uncertainties in dosimetry and short follow-up periods. Over the next several decades, time would provide a large amount of data about what happened when humans are exposed to acute doses of radiation. But in the 1950s, most available data and knowledge was limited to effects of exposure to large amounts of radiation. Now let's take a look at what was happening in 1970. It was also the year that the FDA published 21 CFR Part 1000, recommending that patients' gonads be shielded during diagnostic exams. Importantly, the only reason given for this recommendation was to protect the germinal tissue of patients from radiation exposure that may cause genetic mutations. There was no mention of cancer risk or fertility. The concern was solely that of hereditary effects. Shortly following the publication of 21 CFR Part 1000, most states adopted regulations that echoed the recommendation for the use of gonadal shielding. In many cases, states changed this recommendation to a regulatory requirement. However, the Code of Federal Regulations specifically stated that gonadal shielding should only be used when the clinical objectives of the exam will not be compromised. This language, or a variation of it, appears in every state or city that includes gonadal shielding in their regulations. This is an important point and plays a critical role in current discussions about the risks and benefits of patient shielding. Also in 1976, the EPA published Federal Guidance Report Number 9. This report emphasized the importance of proper collimation and, unlike the FDA recommendation, mentioned fetal shielding. However, it too stressed that patient shielding should not be used if it will interfere with the exam being performed. In discussing operator responsibilities, it specifically lists that radiographers should, quote, properly collimate the X-ray beam and use shielding where appropriate and practicable. No guidance, however, is given regarding when patient shielding might not be appropriate or practicable. By 1976, much of the concern about fetal exposure to radiation focused on increased risk of childhood cancer. A lot of work was done to look at health outcomes of children who had been exposed to radiation in utero. However, these data were messy. There was often little or no information available about the amount of radiation used for any given imaging exam, and much of the data relied on parents remembering exposure information, which is subject to recall bias. This plot shows data from the Oxford Survey of Childhood Cancers, with the excess relative risk of dying from cancer per X-ray exposure for individuals who were exposed in utero, separated by birth year. Clearly, the excess relative risk decreased over time. It's likely that this decrease was due to a reduction in the amount of radiation used in X-ray exams during this time period. There's a lot of controversy surrounding methodology and data interpretation. So what happened between 1970 26 in 2019, when the AAPM position statement was released, the Star Wars franchise became an overwhelming cinematic success, culminating in 2019 with the 9th and final part of the Skywalker saga with Star Wars: Rise of Skywalker, a reality TV. Advances in X-ray imaging included changes in image detection technology. Intensifying screens and then rare earth screens both reduce the amount of radiation required to produce a diagnostic quality image. The introduction of digital detectors allowed for a larger detector dynamic range and a wealth of post-acquisition image processing options. It's worth considering the source of the radiation that a patient is exposed to during an X-ray exam. Most of a patient's radiation exposure comes from the primary X-ray beam, with a very small amount coming from extrafocal radiation, scatter from irradiated objects, and tube housing leakage. In addition to advances in X-ray detectors, there were also advances in other X-ray components. Beam collimation became better through the use of multiple stages of collimation, greatly reducing the amount of off-focus radiation that reaches the patient. For modern X-ray systems, the X-ray intensity falls off rapidly outside the field of view illuminated by the visible light field. Less than 1 centimeter outside of the visible light field, the X-ray beam has decreased to less than 4% of the intensity of the primary beam. Radiation exposure is even lower for parts of the body that are farther from the imaged anatomy. Another development has been in X-ray generator technology. This plot shows a difference in the X-ray spectrum produced by a single-phase generator versus a triple-phase generator. The triple-phase generator produced an X-ray beam with a higher effective energy and fewer low-energy X-rays, compared with the single-phase generator. This resulted in lower patient doses, since the low-energy X-rays that contribute to patient dose but not to image formation are no longer present. Continuous X-ray generators, with even less ripple, further decrease patient dose. Similarly, filtration was added to X-ray machines, further hardening the beam and lowering patient dose even more without negatively affecting image quality. Technological advances in fluoroscopy also decreased patient doses from these exams. Image intensifiers produced much brighter images, allowing fluoroscopists to use much less radiation and still be able to view the fluoroscopy images. Coupling the image intensifier output to TVs improved this even more. Things like last image hold, pulsed fluoro, and temporal averaging allowed physicians to have less beam-on time. The switch from analog to digital subtraction angiography allowed DSA to be performed at much lower doses. And automatic brightness control, or ABC, was so effective at reducing doses that now it's required on all modern fluoroscopes. So where does all of this leave us with regards to patient doses used in diagnostic imaging? This chart shows the entrance surface air kerma from an AP pelvic radiograph from the time that X-rays were discovered until today. Note that the y-axis has a logarithmic scale. If we look at typical doses in the early 1950s, and then compare them to the doses in 2015, we see that there's been a dose reduction of more than 95% during this time period. This is substantial and paints a very different picture in risk-benefit conversations of 1953 versus today. By 2019, people have been studying hereditary effects of radiation exposure for almost a century. To this date, radiation-induced hereditary effects have not been observed in humans. Further, advances in cellular biology and genetics have revealed substantial differences between fruit fly and human responses to radiation exposure. For example, thought to be due to their very short lifespan, fruit flies do not have the same DNA repair mechanisms that humans have. Regarding fertility, it's important to put what is known about radiation effects into the context of doses used in modern X-ray imaging. From animal studies and extremely unethical studies performed on humans in the 1960s and 70s, we know that temporary sterility in males can occur at acute doses of about 100 milligray. Permanent damage isn't seen until much higher doses, about 2,000 milligray. The threshold for affecting fertility in females is even higher than it is for males. Compare this to the gonadal dose during an X-ray of the pelvis performed in 2020, which is less than 1 milligray for adult males. Even today, we still do not know exactly how radiation affects a fetus. We may never know the exact answer to that question. But based on decades of research, several professional organizations agree that below 100 milligray, there's no evidence that the risk of tissue reactions increases at any stage of pregnancy, even though the cancer risk has not fully been resolved. But there is agreement that overall, the radiation used in diagnostic imaging is much lower than what is associated with fetal harm. Any associated risk, if it exists, is very, very small. That doesn't mean that this potential risk should be ignored, but it is necessary to be able to compare risks associated with an imaging exam of a pregnant patient with the medical benefits. Now, let us look at the dose a fetus receives when the mother has an imaging exam. There are two general scenarios. Either the fetus is in the imaging field of view or it isn't. The American College of Obstetricians and Gynecologists has established 50 milligray as the point where one maybe should start to be concerned about dose to the fetus. So what is the fetal dose for the first scenario where the fetus is outside the field of view? For any x-ray that doesn't include the fetus in the image, the fetal dose is below 1 milligray. Even for a CT scan, the fetal dose is below 2 milligray if the fetus isn't included in the image. This is far below where there's any evidence of fetal harm. So now let's look at what the dose is to the fetus for the second scenario when the fetus is in the imaging field of view. In planar x-ray, fetal doses are still pretty low. For an x-ray of the pelvis or a 2-view L-spine, the fetal dose is about 1.5 milligray. In CT, the story starts to be a bit different. But even a CT exam through the pelvis, where all of the fetus is exposed to radiation, the fetal dose is around 20 milligray. With the widespread use of iterative reconstruction and other methods that produce diagnostic quality images at lower doses, this value may now be even lower. This by no means indicates that we should scan every patient who's pregnant just for fun. But it does mean that we should feel confident performing an imaging exam on a pregnant patient if it is necessary to guide clinical care. As a wise physicist once told me, not scanning a patient just because she's pregnant is denying pregnant patients the same quality of care as women who are not pregnant. Much is still unknown about the details of effects of exposure to low doses of ionizing radiation. For acute exposures to effective doses below 100 millisieverts, the AEPM says that data are inconclusive. The Health Physics Society states that below 100 millisieverts, any risk is not statistically different from zero. And the ICRP states that data for these low doses lacked statistical power to directly reveal cancer risks. So in short, we don't know the exact answer. But we know that any increase in cancer risk that may be caused by exposure to radiation used in diagnostic imaging is either very, very small and may not even exist. Again, this is a critical consideration in the conversation about patient shielding. So, the big question we need to ask ourselves is, with all of this in mind, with everything we know in 2020, does shielding patients still make sense? Let's take a closer look at gonadal shielding and the role it plays in dose reduction. So again, we're going to look at these two scenarios. The first where the gonads are in the field of view, and the second where the gonads are not in the field of view. In this first scenario, for example, during an x-ray of the pelvis, the gonads receive a dose of about 0.1 milligray for pediatric exams and about 0.8 milligray for adults. The data shown here are from studies that looked at dose to the gonads for x-ray exams where the gonads are not in the imaging field of view or when they're only partially exposed. For adult males, dose from an AP abdomen exam is about 0.25 milligray, and dose from an AP L-spine image is about 0.04 milligray. Dose to an AP L-spine exam is about 0.5 milligray for females. The studies that measured these doses also measured dose of the gonads when shielding is used. For an AP abdomen exam, gonadal shielding reduced dose to the male gonads to about 0.19 milligray. For AP L-spine exams in males, dose was reduced to 0.02 milligray. The gonadal dose to females during an AP L-spine exam was unchanged. What's interesting, however, is that in one of these studies, the authors concluded by stating that gonadal shielding ought to be used for every X-ray exam where the gonads are in or near the imaging field of view, despite the fact that for females, there was no dose reduction provided by the shielding. These data and the author's conclusions illustrate much of the disconnect between medical physicists and other medical professionals in discussing patient shielding. Most medical physicists would agree that a dose savings of 0.02 milligray does nothing to make patients safer. In fact, most would agree that none of the doses shown here will have any effect whatsoever on a patient's health. But to many other healthcare professionals, any reduction in patient dose should be pursued. And technically, this is in line with the guidance provided by Dr. Hodges in 1959. So in summary, shielding anatomy inside the field of view reduces dose to the anatomy covered by the shield. And shielding anatomy that is outside the field of view may slightly reduce dose to the gonads, but I will emphasize that a key part of the conversation has to be the amount of dose reduction and its associated impact on patient health and safety. Something I have not yet discussed is effective dose. In 1977, the ICRP published tissue weighting factors, reflecting what was known about relative radiosensitivities of various tissues. The colon was assigned a tissue weighting factor of 0.06, red bone marrow a tissue weighting factor of 0.12, and the gonads were considered to be more radiosensitive than any other human tissue and was assigned a weighting factor of 0.25. Let us consider the case where gonadal shielding reduces dose to the gonads by 100%. Based on the tissue weighting factors shown here, shielding the gonads could potentially reduce effective dose by about 20%. But these tissue weighting factors were revised in 1991 based on then current knowledge. They were revised again in 2007. Red bone marrow was still assigned a tissue weighting factor of 0.12, but the tissue weighting factor of the colon was increased to 0.12, and the tissue weighting factor of the gonads was decreased substantially from 0.25 to 0.08. So that same 100% reduction in dose to the gonads now reduces the effective dose by considerably less, only about 6%. The increased tissue weighting factor of the colon also means that if, by shielding the gonads, dose to the surrounding tissues increase, then you may end up with an increase in effective dose, even if dose to the gonads is decreased. In other words, changes in tissue weighting factors have reduced the effectiveness of reducing gonadal dose. Okay, so let us revisit fetal shielding. Again, there are two possible scenarios. Either the fetus is in the imaging field of view, or it's outside the image field of view. When considering the role of fetal shielding, it's important to consider where dose to the fetus comes from. For any anatomy that is outside the imaging field of view, whether it's the gonads or a fetus or anything else, the overwhelming majority of radiation exposure comes from internal scatter generated within the patient. This accounts for over 80% of the dose to out-of-field anatomy. This is critical in considering patient shielding because it demonstrates that shielding anatomy outside of the imaging field of view does very little to reduce patient dose because it cannot shield anatomy from internal scatter. So what? Even if patient shielding only reduces the dose to some organs in specific circumstances, shouldn't we still do it? Why bother changing patient shielding practices? The problem with this line of thinking is that it only considers the potential benefits and none of the associated risks. And patient shielding can, and often does, cause problems. First, the benefits I've mentioned regarding patient shielding assumes that the gonads are fully covered by the shield. In reality, this doesn't happen. One study showed that gonadal shielding failed to fully cover the gonads up to 91% of the time in females. Even in males, where the gonads are visible, shielding failed to fully cover the gonads up to 66% of the time. If shields do not fully cover the gonads, any benefits of dose reduction will decrease. This is not a criticism of anyone's skill or expertise. The difficulty in fully covering the gonads has been documented over a number of years. It's usually not due to a technologist making an error, but rather reflects the inherent difficulty in performing this task. In females, the position of the ovaries is highly variable, and even if shields are placed perfectly by textbook standards, it is likely that the ovaries will not be fully covered by the shield. And in both males and females, patients often move between when the shields are placed and the exposure is made. The radiology community has been asking radiologic technologists to perform an extremely difficult and often impossible task. The question is it still worth it? The biggest risk associated with patient shielding, in my opinion, is the risk of obscuring clinically relevant anatomy. In the image shown on the left, the positioning of the gonadal shield looks pretty good. The right side shows anatomy that can be critical for making a diagnosis or ruling out abnormalities. It is clear that the gonadal shield covers clinically relevant anatomy. This shows an image where the gonadal shield used for this female patient likely covers very little, if any, of her ovaries. In addition, the patient is 74 years old and is extremely unlikely to have any more children. In the image on the right, we again see that the gonadal shield covers only a portion of the ovaries and obscures bony anatomy. So we really have to ask ourselves, why are we doing this? A substantial development in X-ray technology was the introduction of AEC, or automatic exposure control. AEC decreased the number of repeat exams and greatly improved the consistency of image quality in X-ray imaging. However, patient shielding can interact very poorly with AEC. In this case, shielding was used on a 9-year-old patient during an X-ray exam of the hip. A typical technique for a patient of this size is about 77 kV and 8 MAS. Because the shield covered the AEC cells, the technique used here was 85 kV and 109 MAS. In addition to the gross increase in dose, the image quality is terrible. The anatomy is not even fully visible because the areas not covered by the shield are massively overexposed. So I like to think of this cartoon here. Thanks. I thought that was pretty funny too. So since AEC and lead shielding don't really go well together, then we're better off using AEC. It provides better image quality, more consistent image quality, and it does a better... So let's take a brief look at the use of patient shielding in CT. This is most often done to shield the fetus, as shown in the images here. On the left, we see the localizer scan with the yellow line indicating the position of the axial scan shown on the right. The artifacts caused by the presence of the lead apron are noticeable and substantial. Interestingly, patient shielding in CT has created some interesting rumors. I've often heard that a reason to not shield patients during a CT scan is because the lead apron will trap the radiation inside the patient and increase patient dose. This isn't true. Lead, and lead equivalent materials, are very good at absorbing X-rays. A lead shield will not reflect X-ray photons and cause them to bounce around inside the patient. Here's another case where patient shielding was used during a CT exam. Looking at these images, it appears that a lead apron was placed on the patient during the localizer exam, but then removed before acquiring the axial scan. In fact, the axial scan looks pretty good. But if you look at the technique, you'll see that the MA for this slice is 500. This is almost twice that of slices in the abdomen that were not covered by the lead shield, and it also happens to be the maximum MA that can be produced by this particular CT scanner. Almost all body CT imaging is performed using automatic tube current modulation. And similar to AEC and radiography, auto-MA algorithms can cause the scanner to increase dose in an attempt to see through highly attenuating materials like lead. So even if the images look okay, patient shielding may be causing problems in less obvious ways. Okay, so TLDR, or for the older folks in the crowd, too long, didn't read. The cons or risks and pros or benefits of patient shielding. Cons. It can cause degraded image quality, have a negative effect on AEC or automatic tube current modulation in CT, and lead to obscured anatomy. Pros. It makes us feel better. I know that sounds callous and a little bit flippant, but it's true. One of the primary arguments for continuing to shield patients is that patients expect to be shielded. It makes them feel safer and lets them know that we're concerned for their safety. But all this does is feed into the cycle of radiophobia. If we continue to shield patients, patients will continue to expect to be shielded. We have taught patients, through example, that shielding them is necessary. We have to be willing to break this cycle. We cannot let fear guide the practice of medicine. We have to be willing to step back, set our bias aside, and critically evaluate the role of patient shielding through the lens of current scientific evidence and knowledge. A couple of final notes. Many times, I've been asked whether we should continue to shield patients for exams where the risk is very, very small. One example is a hand x-ray. Consider the following scenario. A patient comes in for a hand x-ray and an apron is placed over her lap. It won't make her any safer, but the chance that the shield will enter the imaging field of view is also really, really small. A week later, that same patient returns for a chest x-ray. She's not given a shield because there is a risk that the shield will enter the imaging field of view. What message are we sending to the patient? In neither case, whether she's having an x-ray of her hand or of her chest, does shielding provide her with any health benefit. But by providing shielding for one exam, but not the other, we are sending mixed messages about radiation risk. This may seem like a trivial concern, but I'm passionate about giving patients accurate information they can use to make decisions about their own health care. One experience that often comes to mind is with a patient I spoke with. He was in his 80s and had recently had surgery to repair an abdominal aortic aneurysm. He was refusing to have a 3-month post-surgical CT exam because he was concerned that the CT scan would cause cancer. The vascular surgeon had ordered the scan to look for leaky vasculature, which can be a lethal event. For this patient, the risk of not having the CT scan and missing this diagnosis was far, far greater than any risk from the radiation exposure. By continuing to shield patients unnecessarily, we are only feeding this overemphasis on radiation risk, which can have real, tangible negative effects on patient care. So consistency is important. Right after the AEPM position statement was released, AEPM recognized that communication would be a critical piece of any change in clinical practice. It soon became clear that radiologic technologists, regulators, physicists, and other physicians were all discussing patient shielding, but only amongst themselves and not with each other. AEPM created the CARES Committee as a mechanism to bring all of these groups to the same table and use their collective expertise and experience to forge a path forward and determine what role patient shielding should have in the radiology departments of 2020. The CARES Committee is fortunate to have representation from a wide variety of organizations and involvement from so many passionate individuals. There's representation from radiologic technologists and educator groups, including ASRT, AIRS, and ACERT. Physicians are represented through participation by the Society of Pediatric Radiology, ACR, RSNA, and Image Gently and Image Wisely. CRCPD provides a critical perspective from the regulatory community, and HPS and COMP have been ardent supporters of the CARES Committee. I've included some contact information for the CARES Committee here. We have a social media presence on Facebook and Twitter, and any questions and comments can be sent to us at cares@aapm.org. This past December, the CARES Committee published an initial set of FAQs about patient shielding. We are currently developing educational modules and materials and hope to have those ready in the next couple of months. We are also keeping in touch with state regulators about individual state policies as they are revisited and revised. So, in summary, and if you've fallen asleep, now's the time to wake up. Here are the main takeaway points. Clinical practice should be based on current scientific knowledge. The data exists to support discontinuing the routine use of patient gonadal and fetal shielding. Gonadal and fetal shielding are not ALARA. Before I finish, I want to take a moment to thank Mike Solosky, my coworker and husband, and my kids for putting up with the amount of time I've spent on discussing patient shielding and for letting me bounce presentation and song ideas off of them. My immense thanks to the radiologic technologists I'm fortunate enough to work with at University of Colorado Hospital and to the CARES Committee members. Thank you. We need to understand what the risks are and what the risks are not. Optimizing patient dose than lead shielding does. Show host to become the leader of the free world, and no one cared or even knew about COVID-19. Massive changes were also taking place in medical imaging. During this time and into the 21st century, there were advances in X-ray imaging technology and in research about radiation effects. Overall, this led to decreases in patient doses and more information about radiation risks. The United States was celebrating its bicentennial. Viking 1 sent back the first close-up color photos from Mars, and Casey and the Sunshine Band were hitting the dance floor, encouraging everyone to shake their booty.
You ain't nothing but a hound dog. When